Good afternoon, everyone present here. I am Faraz from IJCP. Welcome all the participants on today's webinar, and that is on a very important topic, that is heart failure in diabetes, pathophysiology, and management. And as we know that this is a very important topic, and we need someone expert. Without any further delay, I would like to invite a speaker for this webinar. He is none other than Professor Dr. S. Aruraj sir, and let me share some of the achievement of sir. Sir has done MD, PhD, DSc, FRCP, and distinguished Professor Dr. MGR Medical University, Chennai, and past National President IMA, past National President API, and past Commonwealth President CMA UK, and founder chairman of CHPA UK, and Dr. BC Roy National Awardee. Without any further delay, I would like to invite sir and hand over this webinar to sir. Sir, stage is yours. You can proceed from here.
Thank you. Thank you very much. Good evening to all the participants. We are going to have a brief discussion on a very key topic, that is heart failure in diabetes. There are many complications in diabetes, as all of you know. Can be neurological, vascular, cardiac, cerebral, or anything. But most important thing is heart failure. You will understand by the end of this lecture why heart failure is important in diabetes. I'll just say how this pathophysiology occurs and how to manage this case also. This is the sequence of my topic. That is, what is the scenario of diabetes, heart failure, classifications, what was the management yesterday, today, tomorrow, and beyond drugs also. Diabetes, as all of us know, nearly 422 million population are having diabetes. In the world, mostly in the low and middle income countries. In India, there are 77 million people, and now it has risen up to 94 million, and around 25 million are pre-diabetics, and 1.5 million deaths are directly attributed to diabetes every year. There are many types of it: type 1, type 2, MODY, GDM, LADA, pre-diabetes. The markers of insulin resistant are abdominal or central obesity, PCOD, neck axilla, and there is hyperpigmentation. Genetic markers are there. Precision diabetes, time and range are well known. Now, recently, about 5 days ago, I have seen there is a type 5 diabetes is also being reported, and they will have to all become scientific and approved. Heart failure, the magnitude of the problem is it's a major public health problem. The overall prevalence is from 1 to 12%. In younger people, it is about 3%, whereas people above 65, it is 10 to 24%. Lifetime risk of heart failure at the age of 55 is 23 for men, 19 for women. High mortality, more than 40% of them die. Around 29% of them are readmitted every year, and heart failure leads to high healthcare costs. Now you will all understand why this topic is important. Now global mortality from the International Congestive Heart Failure Perspective Study, it says the heart failure mortality is high in India, around 37%. There is a registry being maintained at Trivandrum Heart Failure Registry, which says the first year mortality is 31%, second year, third year 45%, fifth year 60%. Then heart failure and diabetes is a disease with high mortality. There are many classifications available by definition, by stages, but classification by, the ejection fraction is the one which is being followed now. There is a heart failure with reduced ejection fraction. When ejection fraction is less than 40. And there is a mid-range between 41 to 49. Heart failure with preserved ejection fraction when the EF is above 50. Heart failure with improved ejection, which was below 40, now it has come 10 point, degrees. These are all the clinically appreciable follow-up of the heart failure. There was a terminology persistent heart failure instead of stable heart failure, and heart failure in remission, something like a recovered heart failure. All of them say that heart failure lives with you throughout your life, so that you will have to be very careful. These are the classifications of heart failure. The heart failure can be a low output cardiac failure or high output cardiac failure. High output cardiac failure are very common in anemia, pregnancy, hyperthyroidism, when there is an AV malformation. Commonly, what we see is clinically is a low grade left side failure, left side failure can be a pulmonary valve lesion or lung diseases. And the left side heart failure can be again systolic heart failure, diastolic heart failure. Diastolic heart failure are due to cardiomyopathy, hypertension, constrictive pericarditis, and airway tamponade. And systolic heart failure commonly we deal with in ischemic heart disease, dilated cardiomyopathy, valvular heart disease, or hypertension. That is what is our key area of discussion. As we said, the heart failure is a stage when heart muscle is not able to pump adequate blood to meet the body needs for blood and oxygen. Can be systolic failure when there is reduced ejection fraction. Diastolic failure when there is a filling defect. Acute heart failure suddenly come. A chronic heart failure can also present acutely. There we call it an acute on chronic heart failure. A chronic heart failure is going on for a long time. And the etiology of heart failure is coronary artery disease, nearly 70%. And valve disease, cardiomyopathy, account for only 10%. Other causes include hypertension, drugs, toxins, endocrine disorders, and infiltrative disorders. What is the link between diabetes and heart failure? We are talking about, heart failure and diabetes. What is the link? And it is a bidirectional link. From this side to this side it comes, this side to this side it comes. That's what we mean. The diabetes can cause heart failure. Heart failure can also cause diabetes or aggravate diabetes. There is the diabetes side, there can be undiagnosed diabetes and metabolic effects of diuretics, metabolic effects of beta blocker, increased catecholamine levels, and decreased physical activity. Heart failure, you can't have a regular physical activity. When there is reduced physical activity, the insulin sensitivity is reduced and you have hyperinsulinemia and diabetes. And a diabetic cardiomyopathy is a stage advanced like in products are there, fibrosis of the myocardium, mitochondrial dysfunction, impaired calcium accumulation, mitochondrial dysfunction, all caused by diabetes lead on to a diabetic cardiomyopathy and heart failure. The relations between the duration of T2DM and CVD. As the years of diabetes increases, the incidence of heart failure also increases. If it is less than 2 years, it is only 15%. If it comes to 15 years person, it comes to 48. This is a Canadian data who shows more number of years you live with diabetes, more chances of getting a heart failure. The link between diabetes and heart failure, as I said, the Framingham study says that the diabetic men and women have 2 and 4-fold increase in failure. It can be systolic and diastolic. We call it as a diabetic cardiomyopathy when there is no coronary artery disease or valvular disease, hypertensive heart disease clinically significantly. And from heart failure to diabetes mellitus, decreased physical activity. I told you it goes for hyperglycemia, increased catecholamine levels, sympathomimetic activity, decreased insulin sensitivity. All of them cause, I mean, uh, in diabetes, leading on to heart failure. The risk factors for developing heart failure in patient with diabetes, there is a cardiac risk factor, non-cardiac risk factor. Cardiac risk factor, as we discussed, ischemic heart disease, infarction, myocardial, hypertension, valvular disease, or dysrhythmia. Non-cardiac risk factors are age, chronic heart failure, chronic kidney disease, and increased BMI, longer duration of illness, smoking, and alcohol excess. And this is the treatment history, how it developed, right from Röntgen described the X-ray up to the heart transplant by Christian Bernard, and now the European Society of giving the guidelines for management heart failure is history. To be made it very sharp, before 1980, we did non-pharmacological therapy, bed rest, inactivity, fluid restriction, some digoxin, some diuretics. And 1980 onwards, pharmacological therapy have come. Digitalis, diuretics, vasodilators, nitroglycerin, inotropes. 1990, pharmacological neurohumoral interventions have started. 2000, we have got device, cardiac resynchronized therapy or ICD, LV, leptin acid device. And 2010, you have got gene therapies have also come into it. This is the stages. And the major drug groups in the useful in heart failure, in chronic heart failure, diuretic, aldosterone receptor antagonist, MRA, angiotensin converting enzyme ACI, and ARB, beta blockers, cardiac glycosides, and vasodilators. in chronic heart failure. In acute heart failure, you have diuretics, vasodilators, oxygen, morphine, and beta receptor agonist and dovitamin, which is the drug of choice in acute heart failure. The pharmacotherapy, first principle, we try to target the oxidative stress by using AC inhibitors, ARB, beta adrenoreceptor blockers, carvedilol, nebular. Statins are very useful. You've got multiple effects here beyond lipid lowering. Hydralazine is the arterial dilator and inhibit generation of superoxide and peroxynitrite. And the metabolic modulators comes to a second group, trimetazidine. Now many things have been added into this group. We'll see subsequently. When the heart rate is high, earlier we used to use digoxin, but ivabradine is an excellent drug which reduces heart rate control, which keeps the failure under control. Other recent drugs are RNA group of drugs, that is inhibition and neprilysin, and it reduces vasoconstriction, sodium retention, abnormal growth, which are the key heart failure drugs in chronic heart failure. SGLT inhibitor introduced as an anti-diabetic drug has been found to have a lot of positive effects on the cardiorenal side, and which is being used as a key drug today. Beyond drug therapy, we have open heart surgery, CABG, valve surgery, pericardectomy, and there can be percutaneous intervention like valve intervention, coronary intervention, or cardiac resynchronization therapy. ECMO can be there, and a heart transplant is ultimate. And this is the system that is being followed for American Heart Association, American College of Cardiology, Heart Failure Society of India, giving the heart failure, guideline directed treatment in heart failure. That is stage one is patient is at the risk of heart failure. Even before he gets into heart failure, here the drug of choice is SGLT inhibitor, and he is a pre-heart failure. Here also SGO2, SGL2 inhibitors, AC inhibitors, and if AC inhibitor is contraindicated, mean ARB, beta blockers can be used. When there is a reduced ejection fraction, RNA group of drugs is the first drug of choice, and to be followed with beta blocker, MRA, SGLT inhibitors, and diuretics, and hydrate nitrate can also be used. When there is a mid-range ejection fraction, again diuretics have to be used, SGLT inhibitors, AC inhibitor, ARB, RNA, MRA, beta blocker. When there is a preserved ejection fraction, diuretics, if it is needed, SGLT inhibitors are a key, and RNA are very important. Mineral corticoid receptor antagonists are very useful. ARB are very, very useful. I'll try to summarize the treatment here. Therapies of heart failure reduce ejection fraction. When the EF is less than 40, you start with RNA. That is a neprilysin inhibitor with ARB, and a beta blocker. Usually carvedilol or metoprolol are very good, and MRA either can be a aldosterone or epanolone can be used. SGLT inhibitors, EMPA or DAPA. Very, very start with lower dosage, because all of them have a tendency to reduce the blood pressure, and you optimize and reassess, consider other therapies also. We'll see all of them one by one. Guideline treatment recommendations of treatment in mid ranges. Again, as I told you, diuretics as needed. SGLT inhibitor had to be there. RNA, ARB, AC inhibitor. RNA is a very good one, and MRA also very useful depending upon the ejection fraction. Beta blockers, check the ejection fraction, which is above 40, it is of use. It is very much less. Told it. With the preserved ejection fraction, you got diuretics as needed, SGL2, RNA, MRA, and ARB. And always think there can be underlying cause beyond cardiac. Here, deficiency anemia, a rhythm disorder, hypertension can always be there. You need to keep that and control it. With preserved ejection fraction, as I told you, SGL2, MRA, RNA, and rhythm control are very, very useful. The ROS inhibitors are very key throughout the spectrum of heart failure. AC inhibitors like ramipril, enalapril, lisinopril, or perindopril, very, very useful. And secondly, ARB, telmisartan, losartan, very, very useful either alone or with RNA. Here RNA come combination of ARB with the inhibitors of neprilysin, and they are very, very useful. They are the key drugs as clinician today in maintenance of, heart failure with preserved ejection fraction and heart failure with mid-range ejection fraction, heart failure with reduced ejection fraction. You have to be very careful. Start with the lowest dose, otherwise fall in pressure is very, very common. Beta blockers can be of use in all the three stages. They are carvedilol, bisoprolol, metoprolol is and carvedilol are commonly chosen. You assess the LV function. When it is too low, below 40, otherwise in all these three stages we can use beta block. And mineralogic receptor antagonists, either spironolactone or eplerenone, are very much recommended in all the three stages of heart failure. And SGLT inhibitors are all the, reduction or mid-range or preservation. They are the chosen drugs with diabetes or without diabetes. With diabetes or without diabetes. And SGLT inhibitors are introduced as an anti-hyperglycemic drug. Now it has got a good cardioprotective and renoprotective effect. It may lower the blood pressure by osmotic diuresis. And SGLT inhibitors, as I said, it has got cardiac effects. The pressure is reduced, ventricular remodeling is reduced, flow is reduced. It has got metabolic like uric acid reduction, body mass, ketones, and glucose and insulin resistance. And renal side, natriuresis is there, albuminuria is reduced, fluid retention is reduced. And it has got a vascular effect like endothelial dysfunction is being controlled very well. Therefore, it is a very ideal drug. And the SGLT inhibitor, as I said, it reduces leptin and increases adiponectin, which are very useful for cardiac health. In DAPA, heart and Emperor adding SGLT to RNA group is very, very, very important. If you ask me one question, what the drug that you just to treat heart failure, it is a SGLT plus RNA. Very good combination. Only keep an eye on the blood pressure. There are a few new drugs. One is a Versigat, which is very important. When the EF is effect on endothelial dysfunction, with the lowest dose and of 2.5 milligram orally can be uptitrated up 10 milligram. Hypotension and anemia are important complications. Diuretics in all especially you can with reduced ejection fraction it is mid-range also. In preserved ejection fraction, depending on the need, always adjust the diuretics. And sometimes in heart failure control there is need for speed. You can't go on the systematic line. You may have to combine beta blocker and SGLT inhibitor or RNA and SGLT inhibitor, and MRA you will have to add. And when there is a heart failure in diabetes, control of diabetes is also very important. The diabetes may be totally detected. In those cases, SGLT inhibitor or monotherapy. And if it is a known diabetes not under control, you have to go for insulin. I, for the one, who always recommend insulin. You must have hypoglycemia, which is very much dangerous in heart failure. And in heart failure, diabetes, heart failure, there can be a CKD also. Very, very important. AC inhibitor, ARB are very, very useful. BP control, SGL2 are useful. Phenylalanine is also effective. Sometimes you may have to go for a coronary reacceleration. It can be a percutaneous by PCI or it is a surgical BG, depending on the level of the lesions. There are some needs for additional therapies than beyond the standard therapy. One is hydralazine, as I said, it has a vasodilator effect. It reduces the heart rate. Digoxin, all of us know, it reduces the heart rate and it improves the LV functions. And Verisicate, we just now discussed, omega fatty acid, potassium binders can always be used. And anemia must be corrected. Anemia, usually if the fluid load is not much fresh blood, you can give it diuretic. If you are suspicious of it, give the Paxil or intravenous iron, you will have to give it. See that the iron level is better maintained. There should be a regular vaccination in heart failure patients. Because all these people, when they get into a respiratory infection, the cardiac failure can be precipitated or aggravated. Either yearly influenza vaccine or pneumococcal vaccine has to be there in all cases of heart failure. This is current management of heart failure in diabetes, as I told you. The key drugs are RNA, SGLT inhibitor, beta blockers, and MRI. Depending on the other needs of iron control, vesicate, digitalis can always be started. This is a definite, picture to be kept in mind those who are treating case of heart failure. Beyond drug therapy, the left ventricular assist device can be fitted here, and to improve the left ventricular function, there are usually a bridge for the cardiac transplant only, and but in a resistant failure can be of use. And ECMO is always very, very useful, a veno arterial, which is also a bridge to cardiac transplant. Cardiac transplant is a very tough job, all of us know, donor allocation system, but heart transplant will be the final answer in resistant refractory heart failure. Now, to summarize the drug therapy in heart failure, on chronic, acute or acute on chronic heart diuretics, inotropes, nitroglycerin, acute stage. Chronic stage, ARNI, AC inhibitor, ARB, SGL2, MRA, beta blocker, diuretics, and digoxin, depending on the clinician's choice. Now, friends, thanks for active listening. Now, the summary I would like to again read is the guideline directed medical therapy heart assistant reduced ejection fraction needs 4 medications, which include SGL2 inhibitors, RNA, MRA, beta block. Again and again repeating because I want all of you to remember this. SGL2 has a role in heart failure with mid-range and with preserved ejection fraction also. Control of iron deficiency anemia, hypertension, diabetes, and CAD are good, will give good outcome. Effective control of diabetes is needed without causing hypoglycemia. Revascularization, either mechanical or surgical, may be needed. Mechanical support and LV device may have a standby role. Heart transplant is final. In heart failure and diabetes, SGLT is the key, ladies and gentlemen, today. I'm thankful to all of you for your active listening. And if there are any points that are put in, I love to learn. Thank you all very much.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions. With all your permission, shall we take these questions one by one? First
Please, we
question
will
is, sir,
take. We will take.
yes, sir. First question is, sir, how does heart failure present differently in diabetic patient compared to non-diabetic patient, sir?
See, heart failure, the clinical presentation, pathogenesis are same, whether the patient is diabetic or non-diabetic. The main problem with diabetes is it is easily coming or the incidence is more, number one. Number two, they have an existing renal disease also. Therefore, the management will be resistant. Number three, they will have an extensive coronary artery disease or multiple vessels. May need a PCA or a CABG as soon as you control the patient. And that is important. Otherwise, the heart failure in a non-cardiac and a non-diabetic and diabetic or pathogenesis presentation treatment is same. These are the differences. More common, high mortality.
Yes, sir. Thank you so much, sir, for sharing your expertise on that question, sir. Sir, moving forward, sir, what are the challenges in diagnosing HFpEF heart failure with preserved ejection fraction in diabetic patients, sir?
See, in a diabetic patient, a patient will have signs and symptoms of heart failure. But if you do echo, the ejection fraction will be normal. It is a preserved ejection fraction. It is, earlier we used to call it as a diastolic heart failure. That is with preserved ejection fraction. Therefore, some of the clinicians may say, oh, EF is normal, therefore patient is okay. No. When there is a systemic overload and fluid load, you will have to treat it. And when there is a poor contraction of the, you will have to always evaluate the LV fully, not only for filling or diastolic, but also for systolic. Therefore, you should be able to evaluate fully and start the treatment. This patient is symptomatic, fluid load, and he may go for a renal cause also. Therefore, you will have to start the therapy adequately, may not need much diuretic or larger dose of diuretics, may not need a nitroglycerin, but I mean, SGL2 inhibitors or RNI with or without metoprolol, you will have to give it. Therefore, never miss it.
Thank you so much, sir, for sharing your expertise to that question, sir. One last question, sir. How do we balance glycemic control with heart failure risk? Are there any anti-diabetic agent to avoid?
See, you have to see. If you ask me, there are the books give any number of drugs, SGLT inhibitor or GLP-1, agonist, metformin. But I, for the one, will recommend in the acute stage, you could treat the patient with short-acting insulin. Short-acting insulin 3 times or 4 times. Once the patient is stabilized, I mean, with this SGL2 and GLP-1 agonist, that itself will control the blood sugar. But you may have to add little metformin that will keep the things better. But only major thing is you can't have a physical activity as you have in non-cardiac patient. That is the only thing. And in that situation, you will have to add some long acting insulin also to this. And yeah, again, I'm repeating, avoid a heart hypoglycemia, which is dangerous in heart failure, can precipitate a dysrhythmia and a cardiac arrest. Very important.
Thank you so
Hello.
much, sir. Yes, sir. Thank you so much, sir, for taking out your important time and answering all the questions,
Thank you
sir.
so much. I
Yes,
love to receive my video. Huh?
yes, yeah, I will definitely share, sir. After
Hello.
this, once I end this live session, I will share the video with you, sir.
Thank you so much. Thank you.
Take care, sir, and we would like
It's
to see you in
okay.
future.
It's okay.
Yes, sir. In future also, we would like to see you in with
Sure.
different topics, sir.
IJCP. Yes, yes. For IJCP, I am always there.
Yes, sir. And
Thank
it was
you.
great honor to host you, sir. Thank you so much, sir, for your valuable time. Take care, sir.
Thank you so much. Thank you.
Welcome, sir.